Excellent, thank you. And I'll hand over to Mariano to get started.
Cool, so thank you very much, Anna. Welcome again. We have, before we get started with the cases, I want to remind you about this. Let me show the screen. So this kind of online blog, and it has been very good for me to use it, more than good, like easier for me to just upload there the links and the history. And we may just limit this forum for that, just limit sharing the links and sharing the images. There's always a possibility to start discussions about cases. In addition to the cases, I put some radiographic principles that is kind of a reading material. I started like trying to copy stuff, and then I realized that it was easier for me, a lot more time efficient, just to offer you this website, which I created for the students years ago. I spent a lot of time, and I think it's kind of cool to go through the principles. It's kind of not very complete. The website, I stop at some point, but for things like image formation or image interpretation, you will see that I got here, for example, the game of the grapes, and with little animations. So if you are interested in those principles, I think this is probably a good way to spend some time. Or we are going to come back to what magnification means. And then I created this little video or animation that you can see, trying to make the principle very simple. I anticipate that we will come back to these principles many, many times. So going back to this web, trying to grasp, the basic idea or understanding, it may be a good thing. So you can always, obviously for free, is there on is a website, and you can get it. The address, the name is The Blind Radiologist, and then I put the link here on the blog. If you just type The Blind Radiologist, you're gonna get it anyway. So that is probably a good place, in addition to the books and everything, to go back to the principles. I made a big effort in trying to make it simple with animations and trying to bring the principles to a very simple little story. So having said that, now probably we should get started with the cases. Do you have any questions about the previous cases? We are all good? So then for today, we had like 3 cases that I thought about. If Helen is around, which I can see her, probably, Helen, do you want to go through that case 7, which is this one? Okay. She's not answering, but probably we should go anyway through the case, because otherwise we keep on leaving it behind. So, and the reason I was trying to ask Helen, so did you get the links for this? I haven't sent them. They are on. Oh, let me share the link with you now through the chat, so you can always open the images. So that's the link. So if you want to open those images, you should get the viewer, and then probably I'll give you the history and take 1 minute to see what you think. The history, this is an 11-year-old female neuter setter, presented for acute onset lethargy, trembling, thank you, mildly increased respiratory rate, and a history of regurgitation.
Can I add to this history? Sorry, I'm kind of
jumping. Absolutely.
So this is the case that was seen initially by Helen, but also like I ended up taking over her care on Tuesday. So she'd had a dental, she'd been very well dog, had a dental at the regular vet on the Tuesday, and taken 2 days to bounce back, but then had 3 days of being completely her normal self. And then on the Sunday, had acute onset cough and retch, and brought up something really sort of thick, voluminous and sticky. and then went acutely into a state of respiratory distress.
Mm. So there was this kind of gap of 2 days
Mm-hmm.
in between the anesthesia and then the clinical signs. Okay,
Mm-hmm.
good.
Or
So these are
even
the
5 days, really.
wow.
Yeah.
Okay, good. As usual, I'm interested in your thinking and in what you see, because then it's a lot easier for me to, the things that are right, support them. The things that I think I disagree, I support or I argue against. Makes sense? And give you the reasoning why I may disagree. And that's probably the best way to learn. Makes sense? So we need your active commitment and going forward. So what do you think about this case? These are the 2 radiographs that they were taken originally.
Mm-hmm.
So, yeah.
If anybody's got background noise and can't turn their mic on, just send your interpretations or comments through the chat channel and I'll relay them to Mariano.
Yeah, that's a good idea. Yeah.
It looks to me like there's a grossly increased or decreased soft tissue opacity in all the lung fields, but the lung vessels are visible right out to the periphery, and the heart is raised, and the heart is a very, very clear outline. All the mediastinal structures are very clearly outlined.
Okay, good. There's a lot of food there. So let me review. So you said that there is a decreased lung opacity.
Yes.
Okay, so decrease. And
Oh,
then
I don't know. It just looks very, very, yeah, maybe decreased soft tissue opacity in the lungs. Yeah.
that's okay. We will see if someone disagrees or we'll. But it's a good comment. If you want, you can even show what you are talking about. You mentioned another thing that you said that you can see the lung extending all the way to the periphery. So that's also a very good thing. So yeah, so lung seems to extend to the periphery. Then something else that you mentioned was that the heart seems to be elevated. So another very important thing. So elevation of the heart. Okay.
Can I add there, I think the heart silhouette looks very small.
Okay, good point.
Just subjectively.
Small heart. Okay. Anything else? And again, here we are going.
It's interesting to me that on the Zoom, the image is under, it's overexposed and really makes the changes in the lung fields jump out at me that I didn't really notice when I looked at it on the keystone. So actually, it was like changing the contrast settings. It really made the lung fields jump out more looking at it when the exposure was abnormal and poor, but it really made it obvious.
Okay, good. So now you are making a comment about the technique, if you want, the exposure of the radiograph. Is that related to any of the 2 particular images, one more than the other? Do you think your comments apply to both?
On Zoom, the more dorsal, like the top image.
Cool. Perfect.
Yeah, but on Keystone, the image looks that image looks normal. Well, it looks properly exposed on Keystone.
Are you sure?
I'll go back.
There's actually on Keystone. There's quite a few images from this patient, so it might be one that was taken a little bit later.
Yeah, good point. That's why I decided to. Oh, I can send you the other ones as well as links, but that's why I decided to start with these 2, because these 2 there is a lot to talk about these 2. But then we can go back to what happens in the follow-ups. But if we stay with this one, and if you open the link that I send you, even if I try hard, I don't think I can bring that back to a normal exposure. But let's continue on with the findings. And so I encourage the rest of you to either keep on bringing more findings, but also to disagree. Makes sense to say, that finding I don't see, or do you mind showing me, or I think the opposite. Make sense? So now is where we bring everything on the table, and then we filter out. Make sense? So now we bring everything. Anything else? Anything they want to add?
It looks like there's some degenerative changes in the spine, the thoracic spine.
Agree with that, yeah.
There's a marked, on the VD particularly, there's a marked bronchointerstitial pattern. The border, the cranial border of the heart and the lateral is not even, so that there must be overlying radiodense tissue. I think which is more obvious on the VD, I guess, that's marked interstitial pattern. And the other thing is the cardiac vessels are obvious on the surface of the heart in the lateral, which you don't normally see. And I don't know why that is, though. That's
perfectly fine. Now we are throwing findings without caring if we can explain them or not. Then we untangle them. Can you please go back to your first comment? You said that there was an increase. We are going to come back to this, so we clear up the language that we're going to use. But so I'm interested in more than the pattern. I mean, we can for now say the lung looks very wide or not so very wide, like moderately wide or very wide, severely wide. So we keep it very simple. Can you show me, can you annotate which part of the lung in particular you are referring to?
Okay, so I'm not sure that I can annotate it. It's not bringing up the...
Okay, but so if you, that's okay. But if you need to decide, I give you options. Right, left, middle, cranial, or caudal. So we make it like...
Yeah, what I'm calling the bronchial pattern is most marked in the VD. On to the left on the view of the heart.
So are you talking about this?
Yes.
Okay, good. So I agree that looks like the wall of the bronchus.
Mariano.
Helen, you are also talking about the lung. Do you? No, I'm sorry. Helen is writing something here on the chat, and it's similar to your comment. But I wonder if Helen, do you agree with these changes, or do you want to add something else? And if you want to add something else, do you mind circling, showing us what you mean in terms of abnormal lung now?
I'm not sure I can circle it, Mariana, because I'm just on my phone, but
okay.
Yeah, looking at it on the right, so the left side of the dog, the sort of the caudal part of the left cranial lung lobe looked more white than it should do.
Is this what you're referring to?
More cranial.
I think more cranial.
Yeah, that bit. Yeah.
Good. So there are many interesting things. Hopefully I can come back and I remember everything from what you are saying. This is a DV projection, and something that we need to be aware of is that the lung doesn't really, what I'm going to say may sound silly, but it's probably not. So the lung doesn't really stop here. This is ventral, and that's the liver and diaphragm. Dorsally, so that's this border. But superimposed over that liver, there's a lot of lung. I would say almost all of the caudal lungs are sitting here. Make sense? So if we talk about caudal, I would just be referring to this. This is next to the heart. So this is probably the caudal part of the left cranial. Make sense? It's not to correct or anything, but it's the important point here is that the lung is not stopping here. The lung goes all the way. Do you see the lung vessels? That go all the way. And probably we haven't even included the whole lung. That is going to go a lot more. That shape, we are going to discuss that probably in the future. That shape of the diaphragm changes a lot depending on the projection. If we have a DV or a BD, DV or BD, and how much the lung keeps air and how much contrast. There's a lot happening in between a DV and BD. So we will go through that in detail, but for now, in the future, not today, for now, probably the important thing is to mention that there is a lot of lung. The key thing here is superimposed. And if I come back to the grapes, the lung here, or the lung vessels there are like grapes superimposed over the fluid. Make sense? So the fluid is going to be the liver, and the grapes are going to be surrounded by gas. In this case, the vessels are surrounded by gas in the lung. Make sense? So that is the definition of a superimposition. If in the case of having fluid within that lung, now we are going to erase those lung vessels. Make sense? In this case, it's not in contact. They are in different levels. Vessels here are surrounded by gas. They are soft tissue. They are superimposed over a soft tissue structure like the liver. So we can still see them. Superimposed, but we can still see them. Same comment, and we can start clearing up your comments. When you mention about the cardiac vessels, those are actually, they cannot be cardiac by definition. And the reason why they cannot be cardiac is for the same reason of the grape surrounded by water. So the coronary vessels are in contact also within the myocardium. So unless you put contrast, it's grapes surrounded by water. What we are seeing there are pulmonary vessels that again are superimposed. Makes sense? So in the same way that they're superimposed over the liver, now they're superimposed over the cardiac silhouette. So the difference here is, again, you're gonna get sick of me, you're gonna shoot me with grapes. This is the same example of the grapes. This vessel is a grape surrounded by air, and the heart is another grape, and they are not in contact. We see both contours. Is that all right?
Yeah.
And we will come back to this 100 times. Okay, so we clear the heart vessels, we clear where the increased opacity is. Now the thing that I want to come back is, there seems to be a contradiction. Some of you reported like a decreased lung opacity, and some of you reported an increased lung opacity. So what are we gonna do with this contradiction? Because in my eyes, it's extremely important. So if we see something in one projection, we want to see it in the other projection. If we don't, we need to try to explain what is happening. We need to at least lie to ourselves. Makes sense? We need to find an explanation. Maybe wrong, maybe right, but we should not accept it right away. They can be in the same, though increase. They could be increase and decrease, but where are they? You know, what is happening?
Yeah, I think there is both. In this area, you've got the increased opacity.
Okay.
And then I think over here, well, over here, you have actually here, a decreased opacity.
Everywhere else. Cool. Cool. I like that. So, however, I'm going to argue that this opacity that you have here before, except this one, is a more normal looking opacity. It's not decreased like here.
I think the lateral is just very overexposed.
Excellent point. Good point. So that actually should be the first assessment in the beginning of the reading a radiograph. What about the quality of the radiograph? What about the exposure? How much we are including? What about the collimation? In this case, it's very likely, I'm 100% sure, I don't know how to convince you if you are not, that actually what is happening here is not that there is no lung, is that we use so many x-rays that now there is no difference between a thin soft tissue structure and the air surrounding that. So we are overexposing. So when we overexpose, things that are small and don't, like if you have bone, like bone you can still see. Makes sense, because now you are at that level of the exposure that some x-rays are gonna be stopped. But obviously there is so many x-rays there that are going through the vessels as well as through the lung without creating that differential absorption. Okay, so can we think about, I'm gonna put myself into arguing with myself, make sense? So what are the options to not having that being overexposed? So I think one option that we should be considering, probably we can consider two options. One option is that there is no lung there. Makes sense? Is it that the lung, now there is pneumothorax, and now the lung is separated from the wall? That is one option. And the other option should be, is it that the lung has now more gas? Is the lung being hyperinflated? Like I mean a bronchial disease, and now cut with asthma, and now so I'm gonna argue with myself and say, if that is so much, I'm gonna argue against the pneumothorax. So if I argue against the pneumothorax, what I'm missing in this case is the border of the lung. Makes sense? Because we should see that separation of the lung from the wall, and we should see that border of the lung. And then even if it's hard, probably you can still see vessels here, little vessels. So that shape, based on that direction of the shape, that could never be the lung that is separated a little bit one way and nothing the other way. Makes sense? So the lung seems not to be separating here and then very separated here. The lung doesn't do that because it always separates towards the hilus. Makes sense? Away from the wall. So missing little vessels here make me think that, and not being able to see the contour of the lung, I think it goes against pneumothorax. The next thing that I'm gonna use to argue against my own idea of pneumothorax is that if that is really pneumothorax, it's severe. Makes sense? It goes up to there. If that is so severe, why is that I cannot see it in the other projection? I should expect some degree of separation of the lung from the wall. So those are two against. I have one in favor. The one in favor is the separation of the heart from the sternum, because that is one feature of pneumothorax. So that, I agree, that can confuse us. And now we come back to why is that we have elevation of the heart with pneumothorax? And basically it's because the lung gets smaller. And the exception to the rule that I at least always try to mention anytime I teach or talk about the separation of the heart from the sternum is that there are two exceptions, or let's say one very big exception. And it's a very thin dog with a deep chested conformation. And in those dogs, basically the lungs can go around the heart and make that impression of elevation of the heart. And the other one that I think is happening in this particular case is that we are overexposing so much that actually there is fat in the mediastinum here that we don't see, but is there. So if I take another radiograph, I bet this soft tissue heart is gonna be against something like more fat. And then you will not have an impression of elevation of the heart. So that will be you got all my thinking, for and against, you know, the pneumothorax, why yes, why not. The other idea or explanation to the decreased opacity, not being technical, it will be hyperinflation of the lung. The problem that I have with that is that then I would want to see that in the other projection. And actually, when we have that situation, we have separation, like increased distance in between the diaphragm and the heart. The ribs get more perpendicular, which is kind of in this case, so that's probably not useful. But I would expect to see the same thing on the other projection. And not only I don't see it, but what I see is the opposite, which is increased lung opacity. So I would put all of those features in a bag and then probably conclude that I think the thing that makes more sense is that we are overexposing. So that would be my argument. I don't know if you want to get back on me or argue again. More than welcome. This is the time when we do this, and the residency, I've been training residents for years now, and the residency is all about this. And the way that I see it is, I don't know if I'm going to be able to communicate this in a simple way, but we don't see with our eyes, we see with our brain. So when you see something, if we talk about it and bring explanations, now the brain next time is gonna see the same thing differently, because now you have the knowledge. Make sense? So these discussions about arguments are the way to learn. This is the way to learn imaging. It's reading the book, but also putting that knowledge into play. Makes sense? Into the game, and having people saying different things, thinking different things, and then trying to figure out what's the best explanation. So if you want to make any comments or any questions about that kind of aloud thinking, this is probably the time.
Mariano, my question was, if you have a pneumothorax and the heart is kind of tilted down, can that make it look small when the dog's not hypovolemic?
Haha, good question, and I don't know the answer, but it's a good thinking. I suppose it can make it shorter for sure, because what is happening is when you put the dog on the side, basically the heart is kind of laying on the lung, and that's why you get that length of the heart. If now the lung here gets smaller, the heart falls. It's not that it elevates, it falls. But as it falls, it separates from the sternum. And as it falls, now the heart is gonna look shorter. So I think the shorter part is true. I can see that. I can see that it's gonna look shorter, but probably not thinner. That never ask myself that question. That is just thinking aloud. And I would immediately go to the other projection and see. And here I think I like it. It's very interesting. So here, what do you think about this? Because the heart seems to be more on the left hemithorax. There seems to be no heart on the right hemithorax. So no one mentioned that, but that seems to be the case. And now we come to the second technical issue, which is this radiograph is oblique. So see, the spine is not in the center, and the spinous processes, they are not like small dots. They should be just around the very, very dense thing. So this radiograph is rotated. So because it's rotated, now we don't know if that heart moving into the left hemithorax is real, which will be extremely important in this radiograph. Make sense? Because if there is a shifting of the heart and we have that change in the lung, we may be thinking about atelectasis. If there is no shift of the heart, then we are thinking about something like pneumonia. Make sense? So that piece of information is very important in this case, and probably we have no certainty because of another technical issue. So we are dealing with two technical issues here that are making our life very complicated, and it would be so simple not to have them. So the reason why I enjoy is because now you see by yourself how a technical, something that may take one more minute to do right, it may have a very big effect at the end. That you basically rely on the perfect positioning and perfect exposure, because otherwise the limitations are big. Okay, any other question? That is a good question, Helen. I never thought about that, but you're right. As it falls, the heart, I think, is going to look shorter. So that's a good point.
Mariana, can we discuss whether there's a megaesophagus here?
Okay, cool, because that was the other comment. And actually that comes together with something about seeing too many structures, and I thought there was some kind of implication of having a pneumomediastinum. So I tell you what is abnormal in this case, and what is abnormal is our ability to see that line. We should not be able to see that line, and you should probably not confuse that with the scapula. So I'm going to bring all the possible confusions. This is the line of the scapula, and I came back and I joined the scapula here. I've had myself and residents, when this line goes like that, you think it's the esophagus. So that's an easy problem. So always make sure that you're not talking about the ventral contour of the scapula. One is there, the other one is there. Okay, so that's not that. And then we have that line. which we should not be able to see. What is dorsal to that line, that soft tissue structure, is called the longi colli muscle. It's a muscle that flexes the neck and it inserts there. So that is normally there. The reason why we don't see it is because that muscle is surrounded by soft tissues, grape surrounded by water. If we put against that muscle gas, now we see that contour, grape surrounded by air. Two options to get gas against that muscle: gas in the esophagus or free gas in the mediastinum. Makes sense? So when we see that border, is one of these two options. There is a similar thing, which is also abnormal or not, which is our ability to see this dorsal contour of the tracheal wall. We should not be able to see that. The normal trachea is more like ventral here. So here we have gas in the trachea and soft tissue outside. The outer contour of the tracheal wall is not clear, like here. This is abnormal. And same thing, two options. We need gas on the other side. Same two options. We're going to have gas on the other side if we put it in the esophagus or if it's free in the mediastinum. So these two are two soft tissue structures that are usually against other soft tissue structures that we don't see. And now because we put some gas in between, now we get to see them. Then the next question is, where is that gas? The two options are pneumomediastinum or gas in the esophagus. Which one are you going to pick and why?
I'd say probably in the esophagus. It's too limited to be in the mediastinum, and usually pneumomediastinum usually silhouettes its structures better than a silhouette of there.
Very good. The perfect answer. So it seems to be contained. And why contained? Because if we go here, if that gas will be free, like I'm in a pneumomediastinum, then we will be able to see the left subclavian, brachiocephalic arch, cranial vena cava, and actually most of the time we see the outer contour of the esophagus as well. Make sense? Not only the trachea, but the esophagus, because now that gas is surrounding everything. So agree. That is just gas in the esophagus. Now, are we going to call it megaesophagus? And now we get into the discussion about what megaesophagus mean. If you mean by that that disease process, I don't know. What I see is an enlarged esophagus with gas. So I would stay with a more morphological assessment. Makes sense that the esophagus is distended with gas. If I need to tell you what I think is the most likely cause for that, I think it's because the dog is a bit dyspneic. There is a lot of changes in the lung, and I think he's swallowing air. That would be my first assessment. Can that be the beginning of the story? Could it be that the dog is regurgitation? I think it could. I don't think I can tell in this situation. I'm taking mental notes for the future. There is a lot of things that we can discuss in the future. We need to discuss about, then we continue, like diaphragm. I realize we need to discuss about lung patterns, many things that, I like this because as we talk, then there are many things that trigger future cases, let's say, or discussions, so that I enjoy that. Any other question? I still have some things that I want to go through, but I want to make sure that I give you the opportunity to ask now before we move on.
Mariano, I was confused with this dog because we did repeat that lateral, and the heart was definitely elevated. Okay. I think we ended up getting over 1 liter off both sides of its chest of air, but on the DV, the lung margins did seem to go quite up to the ribs. So I was just surprised there was that much air in there, and you couldn't really see it on the DV.
I'm very surprised that there was any air. Yeah. I actually don't see any evidence of pneumothorax.
Yeah, so that was strange.
Yeah. probably the next thing to discuss is what are you going to do with this. Before we talk about that, I want to come back to this comment, which is very interesting because it's true. Now we see the wall of the airway, and that is the definition of a bronchial pattern. And again, if you go to the book is going to say, and it makes sense, the book says, be careful about calling a bronchial pattern, which is that ability of you to identify the wall of the airway, which you should not be able to, because the wall of the airway should not stop enough X-rays to create an image. With the exception of the principal bronchi. And with that is referring to the first, second generation. So basically in this area. And the reason for that is because those bronchi, they have enough tissue in the wall to generate an image. So I think here we are in that situation where I would probably stay away from calling it a bronchial pattern based on this. This is in addition to the rotation of the radiograph. So basically what is happening, these bronchi are usually there, but by rotating, now you're making them very clear. And then they are so big that I would stay away from calling that a bronchial pattern because they're too big and because of the rotation. So that would be my assessment for here. I would be extremely concerned about these lung changes. That's a very wide lung, it's very patchy. In this area, and I hope it makes sense now, we don't see the contour of the heart. Makes sense? There is an interruption in the contour of the heart. We are going to call that border effacement, grape and water. Make sense? Now the lung is not gas filled, the lung is fluid filled. Fluid filled lung against soft tissue heart. In contact, we raise the contour. Same principle to explain why we don't see vessels in this area. Because the vessels are in there, but they are surrounded by fluid. So then that is concerning. Based on it, I'm guessing the distribution is going to be more ventral. I don't know because I would like to see that in this radiograph. But then in my eyes, if the dog is dyspneic, I would blame this. And we are kind of a bit limited, but based on the low affected, and I'm going to assume that it has a ventral distribution, then I'm going to think about pneumonia as the top. And having a history of an anesthesia, my top differential will be aspiration pneumonia. However, now that you mentioned that there were 5 days in between, I'm not sure what to say about that. I don't know if there is a bronchopneumonia rather than aspiration pneumonia that is probably not related to the anesthesia. It feels too long to have 5 days for an aspiration pneumonia to show up, not only on the radiograph, but clinically. So there, I don't know.
That was my question as well with this case. It just didn't make sense. And the dog was seen to have a vomit and aspiration event essentially immediately before presentation with acute respiratory distress.
Yeah, so in my eyes, like what we know is like, if let's say there's a dog that vomiting and you think there's aspiration, like in this morning, and you bring it over in the afternoon and you take a radiograph and we don't see anything, I always warn that the images, the radiographic changes lag behind. And the reason why they lag behind is because the radiographic changes are not only due to the aspirated material, but also to the reaction of the lung to that aspirated material. So, and that may take a little while. Now, in that situation is a situation where there are clinical signs immediately, and what is lagging behind is the image. And I don't think that takes 5 days. I don't know the number, but I would anticipate hours, 1 day. So this situation where there was this anesthesia, possible vomiting or aspiration, and then 5 days to really become clinical, I don't know what to say about that. This is very unexpected. I don't know, I would probably consider that these are unrelated things, or there's something happening in between. That would be my assessment. I don't think I have more evidence. Next question, and this is a purely imaging question. Do we know, okay, we don't have a marker. We keep on fighting technical issues. do you know if this is a right lateral projection or a left lateral projection?
No, I didn't take that one. Sorry. Blame it on the nurses.
Can you guess? I know which one it is.
Oh,
That's the crew of the
yeah.
Yeah.
So,
The crew are important, but I can't remember which one is which.
So no memory. I think I have like a memory like this. So I make sure that I find an explanation for everything that I can. So then I keep the memory for the things that I really needed. So I'll give you a story. So it requires very little memory. So the story goes like this. Do you remember the Colvena cava? If it right or left? That's the little thing that you need to remember.
I think it's right.
Very good, and because the aorta is left. Makes sense? So, and that's again a very familiar thing, so a lot easier to remember. So if then the Colvena cava is gonna go into the right cruise. Make sense? That is easy to remember. The next thing we need to figure out is which one is which. If next thing, when you put the dog on the side, the one that is on the dependent side, the cruise that is on the dependent side goes cranially. And that is also easy to remember because it's physics. Makes sense, it's just gravity. So if you put the dog on the left side down, then the left cruise is gonna go cranial. If you put it on the right side down, then the right cruise is gonna go more cranial. So if you have these two statements, which are very easy to remember because they feel very natural, then the next thing that we need to decide, we need to be able to identify this as being right or left, or this as being right or left. Makes sense? Because if I can figure and decide that this is going to be left, then that's it. This is a left lateral projection. So how to do that? We come back to the Colvena cava. That's the Colvena cava. And it's going beyond. Makes sense? It's not getting into this cruise. And why do I know that? Because if the Colvena cava goes through and it goes into that cruise, it's going to be like a grape surrounded by water. We won't be able to see the Colvena cava. The reason why we see the Colvena cava extending beyond caudally to this contour is because it's surrounded by gas. Therefore, this has to be the left. This has to be the right. And actually, as it goes through this line, then you don't see the Colvena cava anymore. Makes sense? So here is surrounded by gas, here is not surrounded by gas. If here is surrounded by gas, that has to be left. So this is a left lateral projection. Why I'm spending all this time for that? There is a reason, and the reason is, do you think having a left lateral versus a right lateral has any effect in your ability to see these lung changes?
Yes.
Yes.
Yes. So how is that operating? Can any one of you tell me? And in the meantime you think, I'm gonna bring a beautiful case. Anyone interested in explaining how this works?
The dependent side is more compressed with less gas in that those lung fields. So that soft, the fluid opacity in the left side there would be kind of, I suppose, hidden because everything else is kind of got some form of atelectasis because of its dependency.
It's interesting that we always bring the compression, which is interesting. Let me grab this. It's a very interesting example.
Or deflated, I guess, is probably better.
Yeah, that's a better word. So is atelectatic or air-filled. Makes sense? So that if you take it like that, so let me share with you this one. Okay. So technically this is a nicer case, and then we'll go through fast. I think it's going to illustrate what I want to illustrate. So let me show you first that. So this is a dog with aspiration pneumonia. This is the This is a very clear case. This is the right middle lung lobe that is abnormal, and it does everything we need the lobe to do, which is so wide, is so radio opaque, that is silhouetting, borderly facing with the heart. And if you look carefully in there, they are air bronchograms. We will leave it there for a minute. And the thing that I want to concentrate on is this. Now we have two lateral projections. Oh. Okay, left lateral projection, right lateral projection. I can see an abnormal lung here. And probably let me make it better. Okay, do you see it now? So that line is not actually the contour of the heart. That is the contour of the heart. And now we see kind of a triangle, if you want. There is more opaque, more wide compared to the heart and compared to the other side. Do you see the other side? So on this side, we see vessels, beautiful vessels, wide, beautiful vessels. In this one, we don't see vessels. We see what I make the joke with students. These are kind of the anti-vessels. Make sense? Vessels are white. These are black. Do you see the difference? Okay, so what is happening here is this is a wet lung. The vessels that we see here, we don't see there because they are grapes surrounded by water. The airway that we see here, we don't see here because here is air surrounded by air, nothing. Here is air surrounded by soft tissue, and therefore we see it. Make sense? So this is the famous air bronchogram. There's actually nothing going wrong with the air in the airway. What is wrong is the tissues around that airway, that because now they are more wide, they are kind of highlighting or contrasting with the gas in the airway, and we call it an air bronchogram. But at the end of the day, it's just a wet lung. It's just fluid in the lung. After saying all of that, I wanted to come to this point. Are you a bit shocked by your inability to see it on this radiograph? The changes are severe. I'll bring them back. I'll bring it back here. Those changes are severe. That lung is pretty wide. There is a lot of fluid in that lung. But if we come to this projection, we don't see it. We see it here. The thing that is going on here is very interesting, and it's again the thing of the grapes. If we put the dog with the affected side down, the lungs that are neighboring that affected lung are going to become atelectatic. They're going to lose some gas, and they're going to look similar to the one that has pneumonia. Make sense? The one that has pneumonia is more wide, not because it's atelectatic, but because it has fluid. The neighbor lungs are going to become more opaque because they're losing gas. Different reasons, they look similar, and therefore we can't differentiate. If we turn that dog around, and now the affected lung is surrounded by very nicely aerated neighbors, now we can see it. In other words, and this is, I'm sure, going to be surprising for some of you, because we position the dogs on the side and use horizontal beam, which is only vets. In the human medicine, you are standing. Make sense? In a horse, you are standing. There is a price to pay. And the price that we are paying is that in a lateral projection, we are, let's say, it's not that bad, but you can assume that we are only looking at the upper lung. Make sense? So if you take a left lateral projection, you're looking at the right lung. If you take a right lateral projection, you're looking at the left lung. And that explains why, in this case, which is technically beautiful, why we don't see in the right lateral projection, we don't see changes that are occurring in the left lung. Sorry, right lung. Is that okay? It may be counterintuitive, it may be hard to believe. This is a beautiful case to show that. So if we come back to the other case, so it's not only the reason why we don't see these lung changes. The reason is probably both. First, we are overexposing. Second, is the wrong lateral. So I would trust those changes, and I would say, in order for me to document those better, I need to take the other projection and correct the exposure. Okay. Any questions? I think we kind of cleared everything.
Oh, I had a quick question just when you were talking about the bronchial pattern being visible there because they're large bronchi. Do you understand that if you were to want to interpret that as being pathological, do you need to see a bronchial pattern in a more generalized area? Like if bronchial pattern is real, is it always generalized or can it be localized?
Okay, a good point. More than the word generalized, I will be concerned about at which level are you picking in the bronchial tree? Are you picking the principal bronchi or are you picking a peripheral bronchi? So
yeah, so the little ones. Like
you need to pick the little ones. Don't come here and say, I see the wall of the airway there. You will always see it. That's not abnormal. I show you, just lucky, I got the mother of the bronchial patterns. Happy to go next times and go through lung or thorax a bit more because it's useful. So this is the mother of it. And I would always try to go to the periphery, like see, try to pick an airway there. I would stay away from this area. So these are in a bad area, but they are small. And that means that probably they are not in the hilus, they are more in the periphery, superimposed. But I always try to go similar to the Mets, go to the periphery.
And does it need to involve more than one lung lobe?
No, it may be a situation where, I don't know, I'm thinking, if there's a foreign body in the airway and now it stays within one lobe, that's going to be a situation, uncommon, but that would be a situation where you have a bronchial pattern in one lobe. So the distribution doesn't make the pattern.
Okay, yeah, cool.
Okay. It's interesting because you participate and you put your ideas out, and which is actually the cool thing. Then we go just one case, which I think is how it should be, because we really go deep in the case. You really tear it apart rather than going fast. And I think that's the way to learn. So I'm glad. And it's less work for me. I just pick one case. I always have more just in case. But yeah, this reminds me of residencies. The residencies are these. Residents go and work, and then once a day for 1, 2, 3 hours, we have these conversations, and it's all about this, and it's lovely. Yeah.
Good.
I will for the next time. I'm gonna we're gonna get started with the obstructive pattern in the abdomen, like the foreign bodies, and I have like 2 or 3 more that kind of, once we go through them, we kind of make a little package of the rule, how it works, the usual cases, and there's 2 or 3 coming unusual, which I like to bring to challenge the rule. Makes sense? So we went through the rule, and now we're gonna challenge the rule. We're gonna bring unusual. After that, probably, and the reason why I think is important is you as a primary veterinarian, like a GP, I think knowing how to read abdominal radiographs is super useful. Like, it's easy to do, and it gives you so much information. So I was interested in kind of bringing that to a little bit of an end, and to bring a group of cases that are around the same idea. And then probably the next thing would be thorax, which again is extremely important and extremely useful.
Sounds good. Thanks, Mariano. For anybody interested, Kelly, the dog that was in the radiographs today, was in hospital for 3 days with management of aspiration pneumonia. The initial pneumothorax never recurred, and she made a full recovery and went home fighting fit.
Oh, thank you. Can you get a liter out of a dog's lung actually from the lung if there is no actual pneumothorax?
Probably not, because normally you'd sort of collapse the lung, but you could certainly cause an iatrogenic pneumo and then drain that in the process of doing a tap. So yeah, I don't know where that air came from. I'd be very surprised to, I think you'd be really lucky to get into an airway big enough to give you a litre of air on one side, let alone both.
I think she clinically improved a lot as well after they drained 2 litres of air off. Her oxygenation was much improved. So I think why they thought it would still, yeah.
Cool.
And the other thing, I guess, clinically, we do see pneumothorax with severe pneumonia because of the kind of loss of strength of the lung tissue. We're more prone to rupture, but not acute onset pneumonia. So, I mean, time frame wise, it would make more sense to me if she'd aspirated during her dental and then coughed and ruptured a lung, and that's what caused the acute deterioration. But we just don't have radiographs demonstrating a pneumothorax to support the presence of the clinical pneumothorax. So it's just a little bit of an unanswered question. I did a sneaky study in her, just because there was a little bit of a trace of a pneumothorax there.
Okay.
Could have been iatrogenic from the tap the previous day, but it certainly wasn't redeveloping in any significant volume, and she just improved really as you'd expect of a dog with aspiration pneumonia.
Cool. Thank you.
No worries. All right, so next session is going to be Dave on Friday with the medicine rounds, and that will be 1 p.m. I'll put these rounds up on the app as usual, so if anybody missed out, then go there and tell anybody in your clinic to go there to look for them. And the radiology forum that Mariano put up, if anybody hasn't joined yet, I'll send out another email to everybody with the instructions to join that, because it's going to be such a valuable resource that we can then go back and revisit radiographs and things like that. All right. Thanks everyone for coming. Thank you so much, Mariano. That was great, as usual.
Thank you. That was really fabulous.
Thanks so much.
See you next week.
Thank you.
See you guys.
Thanks. Bye.